The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone, and thank you very, very much for your interest in our strategic plan and presentation. This afternoon, in just a few minutes, we're going to get started with presenting our 2020-2023 strategic plan, and we're excited about sharing that with you. And once again, we appreciate you coming on. We realize that this is not the normal way that we have presented our strategic plan in the past, and in fact, we would much prefer to be able to be with you in person so we can see your expressions and to kind of know if there's a question on somebody's mind. But we're going to make use of this technology and see how far we can get. So we're going to just let it maybe another 30 seconds or so for a few more people to join. Right now, Kevin Covert is our organizer. I think he has everybody on mute. But just to give you a little bit of the format, we're going to go over our strategic plan, and then at various points of pause, we're going to take questions. And we would certainly invite you that if you have a question about anything that's been presented or anything else, or let's say it's a previous section, an idea comes up, don't hesitate to ask a question. That's what we're here for. And we look forward to your feedback. And again, we're reviewing the strategic plan. This is what we use as our process. So I'm going to take a look and see how many people we've got on here. And again, we want to make sure that we're respectful of everybody's time. So we'll try to get started right on time here and be moving along. So let me begin by talking to you a little bit about our process of our strategic plan. First of all, strategic plan is very important to an organization, and it's I really think that it's your guiding document, it's your guiding process. And in our organization, we have always worked with a strategic plan, which is sort of like the foundation on which we build. In our regular process, and I'll talk about what it is now, because it wasn't only but a few years ago that the Internal Revenue Service and our federal government decided that hospitals needed to do community health needs assessment. Well, we've been doing community health needs assessments for years as part of our strategic planning process, but they put it on a 3-year lope. And so now our ability to remain as a tax-exempt organization is dependent upon doing a community health needs assessment. And out of that assessment of the key needs of our community, we have to do a community health improvement plan. And so those documents are done. This is our review of our strategic plan for your benefit. And we are on a 3-year lope. I like to say it that way, where basically we do a complete ground up review of our strategic plan from soup to nuts and modify it. But on a regular basis, annually, we do take a pretty in-depth look at our strategic plan, modify it where we have accomplished things, come up with new ideas of things we need to add. And every six months, we do more of a very, kind of maybe on the off 6 months, we do just a little bit less of a review. And then we're back on our 3-year cycle again. So just so you understand that, we do a strategic plan and modify it. Every January, we then put our administrative goals and objectives, both from the administration department as well as other departments in the organization. And following that, we do our budgeting process. So we budget to our goals and objectives, and then of course to our strategic plan, so that the strategic planning process and our administrative goals and objectives drive our budget. So that's the way that we utilize our strategic plan in terms of the functioning and the governance of our organization. Okay, so I'm going to first have Kevin's put up there some revisions. In our strategic plan, it's a one-page document, and that'll be up on the screen in just a second. We make it very simple to see where we're at and what we're doing. The first thing we look at in our strategic plan overall is our mission statement. This year, our board decided to simplify our mission statement and broaden its perspective. So it's very easy to memorize. The mission of Good Shepherd Healthcare System, or Good Shepherd Healthcare System's mission, is to improve the health of our community. Very succinct, very broad in its spectrum, and it allows a lot of different activities to be, or that mission statement encompasses a lot of activities that we can do in our community to demonstratively improve its health. So that's our mission statement. I would encourage each of you to read it over, see if you can commit it to memory. Shouldn't be too hard. Next is our vision statement, and this is the direction we're heading and what we're going to be doing. Again, this was modified a little bit, this strategic planning session, from perhaps what you've remembered as seen on the wall or whatever. We'll have these out very shortly if they're not already there. Vision: Good Shepherd Healthcare System will be chosen for responsiveness to community wellness, patient care, and strategic relationships. Certainly we want to be focused on wellness. Wellness beats taking care of somebody who's sick any day, in terms of if you can get people well and they don't get sick, you're way ahead of the game. And that's part of our mission. Of course, patient care, when people need care, is extremely important. And finally, even though our board would like us to maintain our independence as an organization, we recognize that as the world gets more complex, and certainly healthcare, that we will probably in the future need even more strategic relationships than we have now. We have quite a few now. And our strategic relationships are what help us to maintain our independence, if you will. We have some very good ones with some very excellent partners. Next is our values. And this year we specifically identified that our values are an elegant ladder. And as such, the first value is more important than the next value, if you think of it that way. First value is quality. Next is compassion. Third is courtesy. And the fourth is value. We also have up here a definition of what we've considered each of those values to mean. So under quality, we're committed to excellent quality, which includes clinical outcomes, safety of patients and visitors and staff, as well as patient, family, and payer satisfaction. This is an important aspect of the larger focus Good Shepherd has on the quality of health care we provide, which is our most important value. So there it is, right? Says it right directly. Quality is our most important value. We will continue to work on reducing variability, meeting all of the standards that we need to make, as well as continuing to push the bar up of the outcomes that we have. Next is compassion. Again, another very important value, and the board has chosen to define compassion in this way. We will show patients and families that we empathize with their pain, problems, and anxieties. We will demonstrate that we care by word and deed. Compassion is very important, and again, it's sort of iconic in the way in that many people, they may not have the sophistication, they may not have an understanding of the esoteric knowledge that caregivers have, but they certainly understand compassion when they receive it or don't receive it, and it becomes, in that sense, iconic in that they translate the compassion they receive to the quality aspect of the organization. Next is courtesy, another very important value. We will be courteous to patients, families, other staff, physicians, visitors, and vendors. We will anticipate people's needs. We will maintain a professional appearance and behavior. Courtesy. And finally, value. And this value is differentiated from the concept of our values as attributes of our organization. This value relates to, the equation of quality over costs. We strive to achieve the best results in the most efficient manner. And again, healthcare is extraordinarily expensive, We want people to feel and perceive that they receive value when they come to the organization. Therefore, we must be efficient in our operations. So those is the mission, vision, and values. Just a little bit about our process. As we went into we go into a strategic plan. We do a lot of service area reconnaissance. We gather information from our community on their perceptions to the hospital. We gather various types of demographic information, patient origin information. We have lots of surveys in our community about their perceptions again at the hospital and the care that they've received from patients. We have a manager retreat where we take our managers, probably one of our more rich source of information that goes into our strategic plan from the people who are most directly connected with patient care. Our medical staff, we do a survey of our medical staff, and of course then when we take off for a little bit of a retreat, we have our board members, we have our medical staff leadership, and we have our administrative team that come together to put together our strategic plan. So the way our strategic plan is organized, we've done this for a number of cycles, but this year we have 5 main strategic goal areas: quality and safety, physician and clinician partners, and that covers our physicians and our mid-levels, et cetera, and how our relationship to them in the strategic plan. Next is healthcare system of choice for patients, providers, and employees. Next is strategic growth and positioning, where we're going to go next in terms of new services. How do we set up our services in a competitive environment, with best positioning, and finally our financial and operations focus. And so as we get into each of those areas, we're going to let some of our vice presidents talk about each of those, and that again you'll see an accountability over the far side as to the key person who works with and making those strategic goal, the metrics, and the strategies. Now, for each of the strategic goal, there is a 3-year metrics. That's what we're looking to achieve by the end of the 3-year cycle. And then the strategies doesn't mean it's an exhaustive list, but it begins to talk about the strategies that we're going to utilize to achieve those metrics. So I'm going to go ahead now and turn over this quality and safety strategic goal to Jim Schlenker to talk about that. So, Jim.
Good evening, everyone. You know my name, hopefully, is Chief Operating Officer, and as you can tell, I'm not the VP of Nursing. Teresa Brock, who after 13 years retired, is somewhere off having some great times with her 15 grandchildren. At least that's what I hear. So I did want to start by saying that we do have a new VP of Nursing. Some of you have received the information, hopefully, but Brian Patrick will be starting September 8th, and so exciting new times for a new leader in that arena. Hopefully I'll kind of set the tone for what the other VPs are going to do, and we're really going to go through the strategic goal itself, touch upon what the 3-year metrics are, and then the strategies, at least initially, to define how do we get to those metrics. And keeping in mind that there's a lot of additional detail that will be done behind this actual strategy of how to get that strategy to work. So at the end of each of these sections, I believe we'll pause momentarily and make sure there's no questions on that section. Again, as Dennis said, you can go back and make sure to get our attention at the end if you have a question that you get in early in the process. So the strategic goal for quality and safety is pretty simple: provide dependable, safe, quality healthcare and wellness services. And you can see how it ties directly into our mission. And our 3-year metrics, we have 3 bullet points here. And the first one is related directly to patient satisfaction scores from Press Ganey, increase our overall and would recommend scores. Our HCAHPS scores that we get from Press Ganey, we want to increase them by percentile points. So just to make sure you're aware, difference between percentile and percentage. Percentile is how we rank compared to everybody else, regardless of how our raw scores are. So to give you an idea, we could have our raw scores go up by 50%, but if everybody else has their raw scores go up by 75%, we're going to drop in percentile points. So we chose percentile points because we know that we have to be competitive and keep up with the Joneses, so to speak. So year 1, year 2, year 3, or you see the 15, 20, and 25 percentile points up from baseline and the previous year, and that's where that comes from. The second one is identify and target 2 social determinants to focus on annually and measure the outcome. And you'll have a little bit more talk about this in a couple of other sections, I believe. But in short, this is not to say we're going to ignore the other social determinants of care. We just want to focus on 2 during this process, if and when we get to a point where we either accomplish something that's valuable in one of those determinants, and or we get to a point where we say, we've done all we can and we don't think we can go any further, let's go ahead and focus on another one, we will do that. And then the third bullet point is to mitigate the risk of an FGHRI level of patient never event as far as harm, as defined by the Oregon Patient Safety Commission. And so if you look those up, you can find out what those specific risks are. We don't have them listed here. But the bottom line is, of course, we want 0 patient harm. The realistic portion is, though, how do we mitigate what those patient harms are, considering that healthcare is a risky business? We know there's always going to be risk. We know there's always going to be some potential level of issue. We want to do what we can to mitigate that and get it as close to 0 as possible. As far as the strategies, the first one, focus on addressing the top 3 quality patient safety issues. And again, these are not at random. These are chosen by a number of methodologies, including looking at, you'll see here in a minute, EOCCO quality measures or MIPS or something internally from our status, or as you'll see later in the meeting agenda, or actually the data as well, you'll see some reference to CMS star ratings. So we want to focus on those top 3 that we know are going to make the biggest impact. The second one, clinical units will focus on improving overall and would recommend scores through active, ongoing, focused strategies. So again, we're going to count on looking at the data from PRES scanning, for example, and digging deeper into it to see, well, what really drives the overall and would recommend scores? Well, these 3 questions do, and they have specifically to do with this area. And how do we go back to the departments that can affect that question the most by increasing, improving patient care, by increasing communication, whatever those things are. And that's what that's referring to. And then similarly, we want to maximize our inpatient and outpatient quality measures. So we have lots of groups that we, I guess, report to and monitor. EOCCO, as you know, is our Medicaid arm here in the region. We also do MIPS and MACRA and ECQMS. So what we're talking about is how do we maximize our potential for both clinical perspective and also, honestly, for EOCCO, for example, for financial perspective, because as we do better in each of those areas, there is some financial incentive to improve your clinical scores that we can then use to continue the process. And so we look at that each year. EOCCO, for example, updates theirs, and we share that with our team and our board. The fourth one, to continue and enhance and implement lean processes. So over the last 3.5 years, we've initiated our Service Excellence Initiative, which is a culture-based enhancement, I guess you'd call it. And we've talked about how we want to be in year 3 and 4 of forever, because we want to continue what we do. This last year, as they start to introduction of lean processes, we introduced the Gemba boards, and your departments have a Gemba board in the area. Right now, I'm pretty sure that they're not quite as utilized as they were pre-pandemic, but we want to get back to that. And that's one piece of how do we use the lean processes. And over the next few months, specifically, I believe in September, we're going to be having some additional availability of education for lean processes to use in what you're already doing in your department, and that is trying to figure out how to solve issues, how to get better what we do, whether it's clinical or communication or both. And then the last one is, again, focus on 2 of 6 social determinants of healthcare as outlined in our CHIP, our Community Health Improvement Plan, as Dennis mentioned earlier, and make significant improvements. Also add additional CHIP social determinants to focus on each of the 3 years. So back to my earlier comment, we're starting with 2, but as you'll see in another section below, of those 2, when we start looking at them, we want to make sure that we show progress, we can move forward. But if we have an opportunity, we're not just going to sit back and say, well, let's wait until the next 3-year plan and then we'll pick 2 more. we're going to continue on the next one and the next one and the next one as appropriate. So that's kind of the information I wanted to share on quality and safety. And if you have any questions, please feel free to speak up. I believe you should be, if you're not yet, shortly off of mute, and you just have to unmute yourself to have a comment.
Any questions on that session or section? Jim, thank you very much. Well done, well presented. And by the way, if anybody, we're looking and trying to check our chat box, as well as Kevin, you can open up and see if there's unmute and see if there was any questions on that.
Yeah, everyone is unmuted at this time. They just unmute themselves. It looks like there's a, let's see, no one is unmuted at this, has unmuted themselves yet.
Okay. Okay, well, again, thank you, Jim, very much. And again, I'd remind anybody, if anything comes to mind, we'll stop at the end of each of these strategic goal areas for questions, and you can ask a question on that or any other previous section as you desire. Okay, the next strategic goal area is focused on physician and clinician partners. And Troy Lagore, our vice president over our clinic, will take us through that section. So Troy.
Thanks, Dennis. Yeah, physician and clinician partners is the strategic goal. And we had both medical staff and board representation at the work group that established our metrics and the initial strategies. So as it says, achieve and maintain an exceptional practice environment that promotes skilled and engaged physician clinician staff and a loyal referral base. And that's a very broad strategic goal with a lot of moving parts to it. So we attached some metrics so we can keep track of our progress. The metrics, as you see, are first and foremost to maintain a 75% physician clinician retention after 5 years of employment. Obviously, long-term employment, long-term relationships with our providers and their patients and the hospital are our desire, and it results in a much smoother operation and more trust and confidence from our patient base. In order to maintain 75% of our physicians and clinicians, we of course have to recruit wisely and hire the right physicians and clinicians. If we don't hire right, not only will some not stay, but some we won't want to have stay. So we need to be wise in the way that we recruit our physicians and mid-level providers. We want 100% of employed physicians, clinicians, RVU productivity to increase to the current MGMA median by 2023. And that's primarily, we want the doctors to be working full-time. We're paying them to be full-time. But more importantly, we want to make sure that our community and our patients have access to all the care that they need locally so that they don't have to leave the area for their care. We have to build in that access with each provider in order to accomplish that, and we need to measure that. The fourth bullet is a progressive improvement in patient outcomes by addressing substandard patient satisfaction or patient practitioner interactions. What that is a lot of words to address the way our patients perceive their care. They perceive their care oftentimes based on the kindness of our physician staff, our medical assistant, our nursing staff. And we want to make sure that we continue to improve that in line with the Service Excellence Initiative. And we have to be able to measure our progress in that. And some of the strategies show how we'll measure that progress. But ultimately, that's patient satisfaction, but it also has to do with our physician and practitioner satisfaction as well. And the next block over the strategies, we want to recruit more primary and specialty care physicians. And at the time that the strategic planning went on, we needed to emphasize recruiting a family practice. Well, that's since changed. We're very, very, very fat with family practice providers within the community, including 3 new family practice physicians at Mirasol, a new family practice physician coming into Family Health Associates, and we also have a new family practice physician already on staff in our own primary care clinic, and another family practice physician that will be here this time next year to complete the medical staff in the primary care clinic. So we're in very good shape for family practice. So we're going to change gears a little bit and go with a little more focus on the specialty practices, including cardiology, psychiatry, and potentially neurology and pulmonology. So that's all within our recruiting plan. We want to also recruit with an emphasis on experienced physicians and clinicians. We've been very good to our new residents and graduates. They can come here, they can blossom, they can thrive. But it's really tough for them to open a practice up when their only experience is with residency. So we're really looking to have physicians join us, physicians and clinicians join us that have a head start and a little bit of mileage on them so that they're able to help us start the practice and expand the practice exponentially so that there's not that learning curve that we have with our new resident graduates. The third strategy is we want to move physician recruiting operations into the Good Shepherd Medical Group division. And that's really semantics more than anything else. The people involved in recruiting will remain the same, but the physicians and board members that were at the strategic planning felt like it was a good fit to shift that because most of the recruiting of physicians most of the recruited physicians are housed in Good Shepherd Medical Group. So it just made sense to align that within the medical group division. They decided that they want to create and establish a physician advisory council. That council would report directly to the CEO. And that council, their largest desire for that council was to have a bigger role in recruiting so that the medical staff had a large role in recruiting and that any concerns that they have, they can take directly to the CEO. It doesn't change things a lot other than physicians are actually assigned to this council instead of being invited to the site visits and recruiting events. And then they, like they do now, the physicians would have input on our medical staff recruiting decisions. Number 5 was to move the ambulatory clinic coding operations staff to the Good Shepherd Medical Group division. That was driven by the physicians, and it was related to increasing productivity. They felt like that if the coders were again housed in the clinics, they would have more access to them and more access to their expertise for quick answers to questions, and that they would be able to, by collaborating with the coders, they'd be able to increase their productivity just because the coders better understood what they did, how they did it, what actually goes on in the exam rooms. The last one, number 6, improve individual practitioner-specific HCAHPS and CGCAHPS scores to exceed Press-Ganey's current critical access hospital 50th percentile. Jim talked about that quite a little bit. It's a concern for the clinics. It's a concern for the doctors and all the other practitioners. They are all individually rated within the CGCAHPS system through Press-Ganey. And that last bullet on the 3-year metric side, progressive improvement in patient outcomes by addressing substandard patient-practitioner interaction. The measurement tool for that and the strategy for that at the same time are the HCAHPS and CGCAHPS. And each of the physicians already that are employed by the hospital already have incentives within their employment agreements to meet or exceed that 50th percentile. So it's a large focus for us with the assistance and the guidance of the lean processes and service excellence initiative. We continue on the track to improve our patient satisfaction. So that was a whole bunch of words. I'm happy to answer any questions that you have that I maybe didn't cover or I confused you as I did cover it.
Thank you, Troy.
You bet. Let me off easy. I like it.
Excellent presentation. Any questions in this particular section by anyone? Okay.
Perfect. Thank you.
All right. Again, thank you, Troy, very much. Well, our next strategic goal area is to become and/or maintain healthcare system of choice for patients, providers, and employees. In that section, Mr. Kelly Sanders, our Vice President of HR, is going to present it.
Hi. So I like this section. It is the meat of what we do. We want to be at least a 4-star CMS hospital. For several years, we've been a 3-star, and sometimes CMS is wavered as to whether they'll continue the star ratings, but they're still open, and so we'd like to become a 5 eventually, but our goal is to become a 4-star CMS rated hospital. We want to increase the provider and leadership engagement in service excellence. We've been very pleased with the Service Excellence Initiative over the last 3 years and want to continue that. And the leadership, both the doctors and the administration, the managers, and the employees need to be able to do that. So we're working on making sure that we are engaged in our service excellence. We want to move all HCAP domains up 15 percentile points. And so we're looking to do that. Constant improvement is a key part of the hospital and everything we do. Physician communication with patients. Our HCAP scores, we'd like to increase that by 20 percentile points each year. And we'd like to increase our nurse communication with patients by 20 percentile points each year. Both doctors and nurses and all of our staff have a large impact on how we're perceived in the community, in the state, at the hospital, and so we want to continuously look at improvement in those areas. So the specific strategies are to take corrective action as necessary to resolve customer complaints. When you get a customer complaint, we'd like to have that improved right away and not have to wait a period of time. We want to try and resolve things when people are here and make sure that our customers are pleased, or at least we are answering their problems and helping them understand why things are the way they are. Number 2 is to develop a patient and family focus council. And this is a new thing. It would be with a board member participating, and we would invite people in the community to come and give us information on what they perceive as things we can improve on and things we are doing well. We're doing a lot of things well, but there's still other areas for improvement. And so the Patient and Family Focus Council with board representation will be a very important part of the next 2 to 3 years. Number 3 is to provide a culture of empathy, focusing on patient-centered care through engagement of patients and families in care coordination and decision-making. A key part of our mission and vision and values is empathy and making sure that we feel for the patient, what they're going through, and the patient-centered care through engagement of patients and care coordination is an important part of what we're planning to do. Number 4 is to improve the top 3 HCAP domains based upon our top box scores. So we want to continuously look for quality improvement, look at the top box scores, look at how we can improve those so that we become an even better organization, which will help us meet things like the 4-star CMS rating. And number 5, use a marketing research firm and a yearly survey to identify public perceptions and reasons for healthcare choices. Sometimes when you want input, you ask and you don't get because people are hesitant. It's kind of like with this meeting today. We ask for questions and we don't oftentimes get them. But that doesn't mean that people don't have questions or don't have concerns. And with a market research firm, an independent looking at things, they can ask, and maybe people will feel a little more comfortable in sharing information with them. So we plan to use a marketing research firm to help us identify any public perceptions of needs and then to make improvements on those. Any questions on that area?
All right, well then let's move to the next section. Jim's up again on strategic growth and positioning.
Thanks again, Dennis. So in this area, we want to provide and facilitate access to services that meet the healthcare needs of our service area. And really, the metrics are pretty simple. We have two metrics. The first one is to increase our market share of key service lines. And we've listed several here. That does not mean it's the only ones we'll focus on. But, you know, OB, GYN, our general surgery, urology, orthopedics, ENT, oncology, which we started back up this last fall, and diagnostic imaging. And we want to do that based on market share increases to be determined on a baseline data. And we're working on getting some baseline data on market share. And some areas are easier to get than others, but that's our goal and our metric is to help to make sure we increase those areas where we can. The second bullet, again, is a little more all-encompassing, and you'll see that in the next section, is the complete implementation of all 6 health improvement priority areas so that are identified in our CHIP, our Community Health Improvement Plan. And Dennis talked about that process earlier of where we get the CHIP from and how it comes from the Community Health Needs Assessment. Well, those 6 areas that are identified in our CHIP that we submitted this past year include the social determinants of health and health equity, obesity, violence, access to services, chronic disease, and behavioral health. And so we talked earlier about we're going to pick 2 social determinants and then try to move forward with others as needed. And that kind of rolls into this section as well. And you'll see here as we get to the strategies. The first one being, we want to monitor our physician referral patterns for key service lines. Now, this does not mean just our physicians who are employed. This means any physician who does business here. We want to know and understand where they are sending their patients for services that maybe we don't supply, or more importantly, that we do and can provide, but we don't. And why do they send them out? Is it because of a cost issue? Is it because of some other challenge? And really try to focus on working with our physicians as the partners that they are in ensuring that where appropriate, they keep the patient's referrals local. The second item is to address causes of out-migration. So this is a little bit broader. Access, satisfaction, quality, and perception, and solve them. Sounds easy, qualitative and quantitative market research. So again, how do we find out more than just what the physicians can give us, but why are some other reasons that people are leaving? So, example I think I gave previously was, potentially somebody could go to St. Anthony's, 35, 40 miles east of here, to deliver their new family member because they have a newer hospital. Maybe it's a nice OB. Maybe they don't like it as much. Who knows? Chances are that could happen. May not. More likely is we might be losing some people across the state line because, one, people think sometimes bigger is better. You've got Providence, Cadillac over there. And two, it might be as easy as, well, I'm going over there for this, and then I'm going to do some shopping in the mall that you don't have, so I might as well stay and do this as well. And so while it might be harder to address some of those things, we still want to try to figure out what the issues are that really are causing people to leave the area for services that we provide. In connection with that, we want to explore, I probably should say continue to explore, because we still do this, partnerships with other healthcare organizations within our community to address service line gaps. So Mirasol locally, we work with them. Lifeways, and hopefully most of you know or have heard, they finally are opening up their acute care 16-bed psych hospital, which is, by the way, on our land that we basically donate them on an annual basis. Family Health Associates, been here a long time as a family health clinic with Dr. Earl and others. So how do we make sure to continue the organization and interaction with those groups to address where appropriate, service line gaps. Sometimes we can't, right? I mean, are we going to put a neuro surgeon clinic, a neurology clinic in here? Currently, probably the answer is no, based on what we do, but we do still offer certain areas, including like cardiology. We don't have our own cardiologist, although we are aggressively and trying to get a non-invasive cardiologist on staff. But we do allow and make sure that there's services here from Cadillac and others to provide services a few times a month for follow-up appointments, those kinds of things. And then number 4, increase interactions with area clinics. So Heppner and Boardman and Stanfield and other small communities around us, while we don't necessarily have a community presence, or excuse me, a clinic presence in those communities, we want to make sure that we have interactions with them about what we can do to support what they're doing, because we're still going to see their patients for many things, hospitalizations, pharmacy, other outpatient services that as a small community, even Heppner, for example, who has its own hospital, are not going to be able to provide. We are the bigger hospital system to them. So how do we make sure to keep those going and take advantage of what that information provides? And then the 5th one, maintain certain volumes by producing the appropriate product lines at a lower cost, both to us and the patient. The big example that continues to come up is diagnostic imaging, partially because there actually is a freestanding DI unit in Tri-Cities. And so while maybe it doesn't seem fair, we get compared to them. We get compared to them because to most people, an X-ray is an X-ray is an X-ray. So if they can do it for this cost, why can't you? And in some cases, there's most definitely a way that we have to figure out how to be competitive with those area hospitals around us to provide similar services. A freestanding service like this might be more difficult, but we still need to know that and figure out if there's a way we can bring those patients in and show value. You saw that in our earlier presentation from Dennis, but what is the value to the patient as opposed to just, hey, I can save $5, I'm going to Tri-Cities. Yes, I know it's more than $5, but just as an example. So manage, increase, and expand as appropriate service lines based upon need or gap in the community at a lower cost to organization and community. So a couple of examples that we've already started going down the path. I mentioned the fact that oncology, while it was here in some capacity more than 5.5 years ago, it's taken us a while, and finally some aggressive recruiting to get Dr. Iacoboni on board. I think he's on tonight. Thank you very much, to help us spin up that service again. And I think while the pandemic has kind of thrown a wrench into everybody's plans, you can now easily see that we're continuing to expand those services, and it is a need for the community, so they don't have to leave the area for services that we can provide here. And I know that that is a very much needed service, and we're very excited. We also started a comprehensive pain management clinic in the middle of June, and again, continue to expand what that really means and what providers that we can put in there. But we built out new space in a medical building next door, and it is running, and we continue to look at services like that where we can make a difference. The last one I'll mention is we are going to be starting up a 3-bed sleep lab service. We actually are in process of rebuilding or remodeling a space where we had a previous orthopedic surgeon who's since retired, and that is expected to be roughly the first part of October, and then we'll start service for that. Again, had some sleep lab services years ago, physician left, haven't really had any sense, and now want to get back into trying to provide that service. So those are 3 examples, I think, of what we're talking about here that we continue to look at. And then lastly, just monitor the CHIP implementation progress and impact on further use of services and market share. I will mention that, you know, we're required to submit that based on our nonprofit status to the IRS. And what they want to see typically is not that we wiped out one of our 6 issues that we put in there and said, hey, you did it, it's awesome, it's 100%, it's great. That'd be great, but they really want to see that we're trying and we're making progress. Sometimes we may try and fail, but at least we're still trying. And so we keep a really close eye on that each year as far as what are the 2 that we started with, where are we with it, are we ready to add another one, and make progress on that as well. And so that's what this really is referring to. And then, of course, as I said earlier, it ties into how do we make sure to provide the services we need, provide at the cost we need, and continue to offer the services as needed and that we can to fill those gaps for the patients in our community that may or may not decide to leave. So I will stop there. And again, if there's any questions, feel free to answer them.
Okay, thank you, Jim, very much for that presentation. Any questions? Oh, there's something in the chat box, it looks like. Well, no, let's see.
That's from Kevin.
Oh, okay. Okay.
Thanks for putting something in there, Kevin.
Yeah.
Okay, thank you, Dennis.
Okay, thank you, Jim, again. Okay, last section talks about our finances and operations. To provide that particular strategic goal as well as the metrics and the strategies is Jan Peter, Vice President of Finance. Jan?
Good evening, and the finance operations section, 3-year metrics. Start out with to maintain our annual operating margin to be above 2% for the first year of our strategic plan years, and above 4% for the last 2 years, years 2 and 3. Our traditional goal has been 4% in prior years, so we're hopeful to get back to that percentage in the last 2 years of the strategic plan. The second bullet talks about moving our departments on a percentile basis of FTEs utilized in each department compared to a benchmark, a productivity benchmark that we tap into for comparison purposes. And we want to compare how our departments are running when you can compare on an apples to apples basis, that if our FTEs are higher than what the benchmark shows, then that gives us an opportunity to lower costs down, potentially do some process revisions to be able to accomplish that, but to analyze what can we do to do better and become more efficient at running each department. The reason we focus on this is because the salaries and the benefits is our #1 cost center for for our operating costs, and the last I checked, it was about 57% of our total operating costs was just that category. So something we want to look at and improve on. The last financial goal was to develop a strategic plan that would enable Good Shepherd to potentially break even if we had to adjust our major reimbursement, adjust to any major reimbursement reduction. So that could be different kinds of things. One of them that's suggested here is if we had to go back to being paid by Medicare DRG rates. And that is in total is a lower reimbursement than what we're currently getting as a critical access hospital. So we want to be proactive, actually looking at what would happen if something, most likely the government, would make some kind of a major reimbursement change to our reimbursement status. On the strategies, #1, you can see ensure Good Shepherd can effectively compete in bundled pricing payer contracts. And so that's important because the insurance companies want to send their members to facilities that are going to offer the most competitive pricing for different types of procedures being done. And so we want to work at that to bundle our procedures, get pricing that can be presented to the insurance companies to be more attractive for them to have us be able to sign preferred contracts. #2, to set total cost objectives to be achieved by increasing efficiencies and product standardization. We talked about efficiencies just earlier about when we talked about the FTEs. We're also another area that we can actually improve on is our product standardization by standardizing on the products we use. We can potentially increase the volumes of those selected products. That then gives us a better position to go out and negotiate contracts with these vendors to get less expensive costs on the products we're purchasing because we're consolidating our volumes by selecting fewer vendors. Number 3 is explore shared risk and or capitated payment contracts with EOCCO. The capitated contracts potentially offer us, if we run the business properly, can actually give us a little bit better reimbursement in total for how we operate and provide service to the patients for EOCCO. Number 4, improve outpatient and also clinic margins through efficiency in different areas like coding, staffing, our electronic health record, and effective provider incentivization and contracting for our physicians. Number 5, achieve and maintain cost per discharge below the Oregon Type A and Type B hospitals. So we have data that we can compare ourselves to the other Oregon Type A and Type B hospitals, which are the rural facilities in Oregon, and we're a Type A facility. And we used to be the leader in the pack on keeping our cost per discharge the lowest of any of those hospitals in that group. We want to get back to that. We temporarily had our average costs raised when we installed Epic the last couple of years, and since this is a rolling 12-month average, we want to work toward getting our average costs down across the board. Number 6, explore alternative / competitive pricing strategies, and Jim alluded to this earlier. And so we're looking at potentially, in order to accomplish that, setting up a tiered pricing system that can be fair and appropriate across the board based on those different tiers. And you can see the different areas that we're going to be looking at. Diagnostic imaging, lab, and surgery are the first 3 that are on the list. Number 7, the last one, identify predatory market practices and develop a strategy for each one. So potentially in the healthcare environment, we can have somebody come in and directly want to compete with us for the services that we already are performing, and we want to keep our eyes open about that potentially happening, and if we recognize it, then develop a strategy to work to make that better. Any questions on the finance area?
Okay, well, Jan, thank you very much for presenting that last section. Once again, Kevin, go ahead and open up the lines. And if anybody has a question on any of our strategic plan, we certainly are here and would appreciate your feedback and any comments that you have. I'm not sure exactly how to, if I'm checking the chat box right, but I don't see any questions there right now. Okay, well, again, thank you very much for your interest in staying with us through a presentation of our strategic plan. And we want you to know that that we do have a fairly involved process that guides our actions in the organization. And even though COVID has come along and I wouldn't say it's derailed much, but it certainly has changed some things and perhaps realtered a few priorities here and there. Our strategic plan is still the direction that we're heading to address needs in our community. We look at COVID as one more disease that is on the plate of things for us to address and handle for our community. And but this our strategic plan is going to go forward here, and it will be, this is our guiding document for the next 3 years. So again, thank you very much. We appreciate that. And if anybody has a question or any that you think of afterwards that you'd wish you'd asked, don't hesitate to give us any of us, send us a call, get a hold of us, run it through your manager, whatever, and we'll be happy to follow up with it. So any last words for any of the other panelists? Well, hearing none, it was our intent to try to keep this right at an hour, and I think we're fairly close. So thank you all very much. Have a very good evening.